So, welcome to my parlor, said the spider to the fly.
All right, yeah.
Completely unrelated to what we're going to talk about today.
Sure.
So, today, I think our main goal here was to follow up on our talk about MI, because we had a brief talk where we went over the origins of MI. I did more of like a lecture style thing on the different components of it. And during this time, you've been doing some training.
Yes.
You've been doing some training.
I have.
And you've also been working with colleagues on how to help them bring that skill set into their practice.
Yes, yeah. So I've been continuing my training with, produced by Bill Miller, and Psychwire is the training that I'm specifically
I'm on
taking.
their email thread too.
Well, there
right?
you go.
And they're really good at advertising, because it'll always say, "Dear Wiplove, we've got a great deal for you." And every time I read it, thinking it's like a friend, and they are sort of a friend, but they have all these big name all stars presenting these, and they're all accredited CMEs.
And it's really, it's absolutely, and it's a really well produced production or education. I find it an easy learning. It's it's not something you kind of look away from. It's something you look into. So you look forward to. So I'm really enjoying it. I did have a question about it, or not. Maybe it's an observation. Maybe it's a question where it's sort of where we're learning about trying to. So I guess in the context of Bill does an interview with a mock client, and this is
a mock client.
Mock client.
Interesting. Okay.
And she has some alcohol problems or alcohol use, I should say, not problems. And she has been sent to him because she was arrested for a DUI.
It sort of counts as a problem.
To some. Interesting though, but she doesn't see it as a problem.
No, but she might see the DUI as a problem.
She sees the DUI as a problem, but more not related to the alcohol use.
Interesting.
Yeah.
Okay.
So, because she doesn't see herself as intoxicated. Another very interesting thing I learned out of that, which I didn't know, is that people with high tolerances blow high on. That doesn't change the breathalyzer for them.
So even if they can dominate a pool game, or they could dominate a video game that has race car driving, but their alcohol level might be a lot higher.
Right, they would still fail the breathalyzer.
Yeah, of course, because it's the level in your body, not like how good you are at functioning.
Right. So, so she's seeing him, and they're doing a just sort of a
20-minute interview?
Yeah, about a 20-minute interview where they're doing an assessment, and then, not an assessment, just a sort of meet and greet, and she agreed to see him kind of reluctantly, and then they go through what I think he called the, I'm going to forget the name, it's something they used to do decades ago where it was the, I don't know if it was...
I know, Cage?
No, Alcoholics Assessment. They used to do free assessments for people that had to see if you had a drinking problem. He used to run workshops for people. That's how he got clients, I guess, or engagement. Yeah. So it'd be a free workshop. You could come in and get this assessment.
Okay.
So he ended up doing this assessment, and I'm going to forget the name, but I'm going to put it in the chat
but
here.
I'd love to learn it, because I'm probably not doing it.
And it includes blood work, and includes a whole workup.
Oh, that I definitely need it, because I'm just I've definitely probably dropped the ball in the last few years.
And so I thought it was super interesting, and so she goes through and gets the liver results, gets these results, does some cognitive tests, and then they were sitting down and looking at the results. So this is I'm kind of shortening up a 3-week process. So now he's reviewing the results with this individual.
Oh, so in this session, he's already had 2 sessions previously?
Yes.
And this is the third one where the person comes back and they're reviewing what the results are.
Reviewing the results of the blood work, of the cognitive tests, and...
Oh, they did cognitive testing too?
Yes, they did.
Like memory, stuff like that? Oh, fascinating.
Yes.
This guy's good.
Yeah, he is good.
This guy's good.
Definitely.
Good for him, yeah. And
so my question is related to this this very nuanced dance, I'll call it, between Bill and the client, right? Where, he's now seeing hard results. There's hard results here on the table that show
evidence.
Evidence.
Right in front. Yeah, evidence. Yeah.
There is evidence that this individual may have some impact from her substance use, from her alcohol.
Yeah.
And then she's there on the other side of the table trying to minimize it, trying to, it's when he says, okay, well, it looks like you're drinking, and we do these studies across America, across North America, and it says that you're in the top 3 percentile of alcohol use.
Oh, it's pretty.
So she
pretty
drinks
heavy.
a lot.
Pretty heavy, yeah.
For women. And
for women, okay.
But then her response to that is, well, anyone else that fills out these questions would be being dishonest. So I'm not really the worst I'm not really in that.
Oh, she was just so honest. That's why she.
Yes, it was her honesty that's counting against her.
Sure.
And okay, so that was the first thing, and then we got into some of the blood work, and where some of the blood work was like, okay, it looks like you're starting to show some signs that the alcohol's impacting, and so now it got impacting your health. Right, and as we know, once it starts showing signs, it can speed up pretty quickly, right?
Okay.
But she's trying to push him back on this.
Okay.
And minimize these results now.
Yes.
So my question is related to kind of this dance where it's like, so motivational interviewing is supposed to be all positive. It's supposed to be all forward thinking, empowering, and this. Now, where does it come in where he's trying to push back a little bit? And saying, no, actually, these, some concern in these results here. And it kind of, it's a little bit, It
didn't feel like MI when you watched them. You're like, oh, this is an MI.
At that point, if you hadn't watched everything else, it didn't feel like MI.
Okay. So what I'm hearing is that you have this patient that doesn't see a problem with their alcohol use. And every bit of evidence either that they say or they're presented with, they have, I'm going to exaggerate, but 1,000,001 reasons why it's not a problem.
Right.
And as you were observing how Bill Miller went through the process, there came a point where he was more direct about the harms related to alcohol in a way that didn't feel MI-based.
Right. And your question is, how does that fit with MI?
Well, how do you do that dance? Because I see where he was going from. I mean, he can't follow down the path with her saying, yeah, you know what? I guess everybody else who fills out these surveys is lying. And you're the only honest one in the room.
Oh, okay, I get it. So you would almost want to validate almost everything she's saying.
Well, that's instinctually the baseline of MI, of everything that, I've learned.
Yeah, so it's just in terms of a twist to that, you have to validate things that you believe are authentic and true.
Right.
So for example, like if somebody comes in and is angry, swearing, yelling, spitting, throwing things at people, I would not validate the fact or affirm the fact that they spit on someone, yelled at someone, threw at someone. What would I validate on them?
You'd validate the fact that they're concerned, that they're here, that they're present,
and they're
angry.
They're angry.
Yeah.
Yeah, you're really pissed off right now. You're so angry right now.
Yeah.
Anybody might be angry or would be angry in that sense.
For what you're experiencing.
Yeah, you can't validate things that are just hurtful or harmful to others. You never validate that, oh, it was just one DUI.
Right.
Right? Like you would never validate that. And so I think I don't know, I think you brought up a great sort of question, and if I had to come up with 2 or 3 teaching points, which is very not MI, because normal MI, what do? I would have you come up with all the reasons. And when you go to a good MI training, it's a good MI training because it feels like the person instructing is doing nothing and you're doing all the work and figuring it all out. And you're like, what is this crap? He should be telling me, or they should be telling me what's going on. So basically, the dance is something that's really interesting. And in the past, I don't know if they went over this in your trainings, there used to be something called the writing reflex.
Absolutely, yeah.
Oh, so you went over that as well.
100%, yeah, and that's so that's the maybe the dance that I'm talking about.
There's a line, yeah.
Is it the writing reflex? Where are you doing that? Are you not doing that? Because you're seeing somebody who's obviously has some issues, right? And you want to help them. You want to write them.
Yeah. So I mean, when we do our trainings and the ones that you've been to, that you've seen, you've participated in, we sometimes talk about different philosophies of care. So we'll sometimes talk about a cognitive behavior therapy approach, an MI approach, motivational interviewing, or dialectical behavior therapy, and all of them have different languages. For this, I'll try to stick with the motivational interviewing language, right? And I think what you're noticing is that he tried to be very careful around not
contradicting what the person was saying, not using yes but language. Yes, but your liver enzymes are high. Yes, but you have a legal thing. Yes, but this is a peer-reviewed study that has this evidence for you to be at that level. He didn't say any of those things, right? And so in healthcare, they have a couple of adaptations to motivational interviewing, right? And what are those? So one of them has to do with how we give advice. Because at the end of the day, I'm technically a medical expert. You're technically an expert of the area that you work in, and you're going to have some suggestions that the person may not have heard of. So how do we do that in motivational interviewing?
Yeah, even when they're asked for, right? Where it's like, when she asked, "What do you think?" Are you really saying what you think? Not necessarily, right? Because she was asking for some input as well, so that kind of opened the door to.
Great.
And how do you not fall in that writing reflex?
So one thing about motivational interviewing is that we try to avoid educating the person, and we try to evoke the responses from them, right? So we try to get them to talk about all the reasons they want to change, all of those things that are there. And the magic occurs when the person says that, oh, this is a problem, I need to make a difference. In some cases, they may not have the evidence. They may not realize that a DUI is a pretty big deal, right? It seems weird for us to say, or that these liver enzymes suggest that there's something really problematic going on. So in motivational interviewing training, they love acronyms, right? So what's a common acronym? They'll use EPE, so elicit, provide, elicit. So what somebody like me might do in that situation is, can you tell me what you've heard about some of the harms or what are some of the signs when someone's drinking too much alcohol? Then you pause and you sort of wait. You ask for permission. Would you be interested in hearing around what are some of those limits other people have decided is a problematic use? And if they say yes or they're asking permission, you can sort of tell them that, usually when there's problems in terms of work life, social life, or personal life, then we start to think of alcoholism as a problem. And I would argue that the DUI is causing some kind of problem there in some kind of way. I would also share that just in terms of public health and public epidemiology data, really once you get into the top 10%, then you're looking at problematic and unhealthy drinking. So it's almost like if you wanted to give advice, that would be the way you do it. So you elicit, provide, elicit. And then the last elicit, E, is to ask them what they've understood about what you've said. There's all these other tools in MI as well. I mean, I'd love to watch the video, right? Because we could almost even dissect it, right? And say that, oh, this is the skill he's using, this is where he veers off a little bit of MI,
Yeah.
Because even with MI, you have to remember what Bill Miller did was he just described what he's doing as a therapist. And then somebody else said, oh, this is MI and all that stuff. But when he teaches on it, he's really just talking about Rogerian psychotherapy, right? He's not saying these are the core principles of MI. He's saying these are the philosophies sort of behind all of it. So I don't know if that covers it a little bit, but the fact that you could find that line, that dance that he was doing, shows that you almost know where that line and the tension is, the room is, and you can tell what the person is comfortable talking about and what they're not talking about.
Right.
And then the magic would happen if it's something, maybe I need to find a way not to get another DUI, right? Or maybe I would need to find a way to get my license back or whatever that might be.
So it's all this whole dance is intended to get the client, patient, individual who's seeing you to come to this conclusion wholly on their own, if possible, or as much on their own as possible.
And if they ask for advice or permission, then you can sort of give it, right? Like, so if they ask for it, or you could ask for permission to share advice, and then you'd be doing it in an MI kind of way, because you can't just ignore the fact that you've had X years of experience serving patients. And what is it now, 6-7 years?
Yeah.
Right? That you've been helping patients, clients with all this kind of stuff. You don't just discount that and pretend that all you know is what they're sharing with you.
Right.
And other things that come up in motivational interviewing, for example, at some point you might have talked about the importance or confidence interval. Right? Like, how important is this for you? How confident you are you can do it? And for me, the second somebody has low confidence, it means one of two things. Either they've just been so detached from having success, they don't believe in themselves anymore. Or the other thing, which is more likely, they may not actually know the steps. Right? So for example, when somebody wants to stop drinking, when somebody wants to get a job, when somebody wants to pass a test, some people know the steps, but other people don't.
Right.
And they need to hear those steps. Well, how do I do it? How do I stop drinking? We both had patients where they're shaking and sweaty all day and they don't know how to stop drinking.
Right.
right? They don't realize this is physiological withdrawal, and they should probably taper slowly or see a medical expert to get the meds, right?
So along that same line, so she was coming to conclusions of, well, because some of the questions on this survey were, when's the last time you vomited because of drinking? In her case, she hasn't vomited for 20 years. Right, so she's become very tolerant of it, and she did speak to her skill set, saying that she could dance, she could do anything after 10 beers. Sure. That most people would, and she was trying to use those points as, see, I don't have a problem with alcohol, and it proves that I don't have a problem with it because it's not affecting.
She doesn't have a problem with vomiting,
or it proves that she has a high tolerance.
Sure.
Which also was one of his points, saying, well, people with the highest tolerance sometimes have the most consequences.
Oh, so what he was doing was he was actually going through the diagnostic criteria with her just to see whether or not she had the diagnosis.
Right.
Oh, that's fascinating.
Yeah.
I've not done that with people before.
No, because you've got the results. So I mean, it is a 3-session. There's 3 sessions involved to get here, right? And and they take you all the way along. So it was really
this
really
is fascinating.
Yeah.
I think I'm going to have to go through those videos and some of the training, because I think one of my problems is because we have patients that have been so much on the AA side, they've been accused of denial. They just get really upset when they're told what to do.
Right.
I'm almost too much on the patient side, and it sounds like Bill Miller has an approach where he's so welcoming to bring them in.
Yes.
But they know when they leave whether or not they've crossed some kind of line where alcohol is really damaging to what's there. And so he tries to get them to leave knowing that some expert thinks they have a diagnosis.
Yes, and it was not, and he was very clear about about saying, what, so she was actually sent in by her lawyer. That's how it got in, the lawyer, to defend the DUI.
Because you have to show you're getting treatment.
Well, you might have to. It might be useful. The lawyer said this might be useful, but he also said, I just work for you and your lawyer. If you don't want these results to go any further than this room, they get destroyed.
Oh, he said that.
Yeah.
Bill Miller said
that. He said, this is between you, your lawyer, and me. And the court doesn't get these unless you and your lawyer determine the court needs them. So that was those were the conditions that she agreed to.
Oh, that's so fascinating, because here in Canada, I have to say that, if there's something around safety, so safety with children, safety with driving, I have to report. Right? And if the records get subpoenaed by the courts, they get shared. I've never had something where I've said this is between me, you, and your lawyer, and I can shred this. So it shows either a huge gap in my skill set in some areas I need to improve in, or it shows differences in the legal system and the healthcare system.
Right.
And also I'm a medical physician, right? So I report to the medical bodies. Bill Miller is a different kind of therapist, right?
Some interesting differences there.
That's fascinating.
Yeah. But it's all the dance to get her to agree to do this blood work and to do these tests, and because I think she was apprehensive of getting the results.
Yeah, I would love to watch those videos. I don't know, how many hours is the training and what the cost is, because it sounds like you can do it asynchronously, right?
Yes. Yeah. You can definitely. It is that type of learning. I think it's. I'm not sure. I'm about halfway through. I think I've got 25 hours of listening into it, so it's probably a 50-hour course.
Well, you're going to get a lot of CME credits from that. Like a continuing education credits for that.
Not that CME credits are very useful for a caseworker.
No, but they have continuing education. They have other stuff as well.
Yeah.
And I think in some areas it's not about your designations, but whether or not you have competence in an area. And for someone like you, I think the real magic comes in if you get to the point that you can train others in it, right?
Yeah.
So you may know with addiction work, there's a lot of turnover, right? So some people will do a job for 6 months, 1 year, 2 years, they switch over. Your kind of consistency, about 7 years of regularly showing up, X number of hours a week is not as common. And I think learning the skill, learning how to train others in the skill, is going to make such a big difference in keeping people around. Because when you're talking about the patient in that mock interview, it would bring up responses in me. You've got someone who literally was charged with drinking and driving and has no concept about how it's affecting society. Right?
Absolutely.
And society.
She was intoxicated and driving, which is kind of the elephant in the room that no one's taught. That was never discussed. So he never got there.
Oh, to the impact on society.
The potential,
well, honestly, the person already sees the impact. They technically are going through a court case, right?
Yeah, absolutely, they are.
And it's how do you find that balance of winning somebody over and also showing that.
But the danger to society is the danger she could have killed somebody.
Oh, of course, yeah. These are really big issues, and the challenge is that sometimes to win somebody over, you almost have to be a little bit selective on the parts that you validate. I mean, if the person asked me directly, hey, is it okay to drink and drive? I probably would have been very direct, like I would have asked for permission first, or would you like me to be honest, or do you want me to find something that's helpful? I don't know. I mean, I'd have to see how it played out. But it's, and everybody I know who works in medicine, if they heard a story where someone was drinking and driving recently, they would report them to the ministry unless they were engaging in addiction treatment. I think that's the standard here in
Yes,
Ontario.
absolutely. Yeah, I mean, we go through those struggles in our RAC clinic all the time, right? Where we have to, whether they're engaged in treatment is a relative term too, right?
Yeah.
So for one physician, it's residential treatment. For another physician, well, they came to RAC once in 6 months. That's engaging, right?
Yeah. I mean, yeah. We should. This is I didn't expect this question, but I think this is a very, very good one. And the part that impresses me the most about your description of it is that you can almost feel that energy in the room around what that line is. Like when the person is going to get upset and lose it at you versus when they're sort of there. And it's so tricky because you want to be authentic. You want to win the person over.
Yeah.
But you don't want the person to leave telling their family, like, screw you, I don't have an alcohol problem. The doctor says it's not me, it's all you, it's your fault. And it's tough because
100%.
you want the person to trust you, and you want, honestly, my number one goal in all encounters is just get people to come back.
Right.
Because once they come back, once you start to build that trust, then you can sometimes almost call them on stuff or have them realize that, hey, maybe some of the choices I make are harming those around me, and they're not matching with what my goals are. But if you say the wrong thing at the wrong time, they just may never come back.
Yes.
It's a very delicate
well, that's
dance.
right. And that third visit was sort of where that was at, right? Because it's like, do you leave, when you're calling out these results, is this going to be the last time you see her? Or is she going to continue into treatment? Or you don't want her to, as you say, you don't want her to walk out of the room and say, everything's great, it's my family's fault. Right? Or it's, it's the police's fault. It's the test's fault. The breathalyzer's broken.
Yeah.
So
I think for me right here, the big take homes is that I need to remind myself of what the basic principles of motivational interviewing are, but I also need to learn a bit more about how it's played out in practice. Because when I've seen Bill Miller talk, he says, I never do more than 2 or 3 sessions of MI. Because after that, then I have people do stuff, right, if they want to. And for me, because I was trained more on
well, maybe as he says that, sorry to interrupt, but that's maybe where it was at. Maybe that was the third session. Right?
Yeah, that's exactly it. So I think
he was done at that point.
Yeah. So I need to know a bit more about his model, because the way that I've been doing it is more on the therapy side, where you integrate it into everything.
Right.
And there's signals in cognitive behavior therapy literature, both for anxiety and for depression. People do better if you mix MI with CBT long term, right? Compared to not. But I think I need to become a bit more focused on the addiction assessment, and then make sure that it's clear to the patient and whoever referred whether or not the person has a significant substance use disorder. And I think I sometimes dance around that issue a bit just because I want people to come.
You always want people to come back.
I always want them to come back, because when they disappear, I don't know what's going to happen. And I've had some horror stories where, like, the person has their whole life together, and then one session, and I don't know if it's something I said or something else going on in their life, and then it's just this train wreck afterwards, right? And you almost just hope, at least especially with the opiates, that they do come back somewhere. Yeah. It doesn't matter if it's where you are or where you're not. I would love to learn more about what your training is like, and I think you can decide if it's situations like this where it's an interesting thing that you're curious about, that you want to try to understand a little bit better, or you want to help me understand a little bit better. But I also think even learning how to take some of the basic concepts and help other people pick it up, because for me, there's certain areas that I don't call myself an expert, but other people would think I'm almost an expert level in terms of teaching around it.
Well, you are an MI trainer, right?
Yeah. I mean, I did go to so maybe in some areas I am a...
By definition, I think you are an expert.
Yeah, but I guess what I'm... Yeah. What
you
I'm
may
saying,
be a modest expert, but in every room I've been in, most people consider you to be the MI expert.
Yeah, so I think the point that I think I'm trying to make is that the way that I became seen as this in a couple of sub areas is that I started teaching other people about it.
Right.
And sometimes I would teach like a resident that was in the room, sometimes teach a small group of 3 people, sometimes I would do a 20-person caseworker, sometimes I'd create these sessions, other times I'd present at provincial or national conferences. And I mean, you've presented at these national conferences with me, right? It's you can see you don't have to be amazing at it to help the audience, just be a bit better than them, right? It's like to teach grade 3, maybe you need grade 4 knowledge. I don't know what the metaphor is. But my point is that if educating others is something that interests you, we can try to figure out if this is a forum where you could present some of these topics.
Sure.
But we'll figure it out. You know, I really enjoyed this discussion, and it really pointed out an area that I need to dive deeper into, because I'm not doing what he does for those sessions.
You're not doing what he does, but the context's a little bit different. But
when I see people in hospital, maybe that's what I need to do. Maybe I need to see them a few times and then get them to come up with a goal. And if they're not ready, I still give them the other information.
Right.
But I leave it less loosey-goosey, right?
Yeah.
Like whatever that expression means.
All right.
So maybe we'll stop here.
Okay. Thanks, guys.
Thank you.
Thanks, Wip.